Moving on, our next presentation is by Dr. Parasuram, Medical Director at Simar Cochin, a unit of Edapal Hospitals Private Limited, Kochi. He'll be speaking on the topic IUI, do's and don'ts. Let us welcome Dr. Parasuram to share his valuable insights on this important subject. Warm welcome, Doctor. Over to you.
Thank you so much. At the outset, let me thank Jashan sir for always calling me to be a part of this. It's indeed a big honor to be in front of my teacher, Sanjay Reddy sir, and the other esteemed chairpersons to be giving my talk. So straight, I will get into my topic of discussion. Intrauterine insemination, what are the do's and don'ts? I think probably as a regular gynecologist or a fertility specialist or even an embryologist, probably this is one procedure that you might think of as probably was one of the most overused, and today it is coming to a stage where it is talked about as the most underused procedure. As each of us know that definitely this procedure has some kind of a role, but then if you ask specifically people as to what is that exact role of this procedure in which group of patients, there's always a thought process, or we might not get a very clear picture. So first of all, we should always understand what are we actually trying to do with an IUI. All we are trying to do is deposition of a concentrated good quality sperms in the available semen sample. That is, we are saying that in poor semen sample patients, we are going to do an IUI, but we are not improving the semen sample. All the good sperms in that particular sample, we are concentrating it, depositing it closest to the place of ovulation at the time of ovulation, preferably in a superovulated female. So these are the basic things that you should always understand while we are doing this procedure. So first, let's talk about all the do's or the best practices that we need to understand in an IUI. For all reasons, the first question that comes to our mind is who. I think for a long time, I think whenever we meet colleagues in different conferences and all those things, we can always talk to them, and when they say that, okay, IUI results, what are your IUI results? Yeah, we get 50%, 70% IUI results and all. So when you listen to something like that, probably people have changed now, but whenever you result to something like that, you think that then there is even no point of even doing an IVF, because when IUI itself is giving you so high results, then you don't need to do an IVF at all. So probably what really happens is not selecting a patient properly. What is an ideal results of an IUI cycle? I would say in a properly selected individual, even if you're getting around 10 to 15% is probably a very good results. And the only group of people whom we might get a little better results is in donor insemination or in patients with sexual dysfunction, where the sperm is never entered into the vagina for it to get to know the fertility potential, or in donor insemination patients in azoospermia, where we know that the sperms is not there. So the only time that you can get a better results in an IUI is in those group of patients, whereas in patients with a genuinely selected for IUI group of patients, your results are probably in the range of 10 to 15. So if you look at the right kind of indications, obviously we all know that there's an unexplained infertility is probably the tops the list. Most of the situations we know that unexplained infertility tops the list. Mild male factor, we know that it's of no use in your severe or your moderate OAT patients. Cervical factor could be because of multiple reasons, probably have some relevance, especially when you're making sure that you're bypassing the cervical factor infertility there. And sexual dysfunction. Again, people do talk about an indication in anovulatory infertility and mild to moderate endometriosis, but we should always understand that IUI is not the treatment for anovulatory infertility or a mild to moderate endometriosis. The reason for infertility is different. But what are we trying to achieve with an IUI is we are at least making sure that whenever this patient is ovulating with difficulty, we are making sure the sperm is present at that point of time. It is not that an ovulation IUI is your treatment of choice. Similarly, with endometriosis, even the mild cases, they do talk about doing an IUI because we are at least making sure that yes, endometriosis issues are there, but we are making sure that the ovulation and the sperms are reaching. So if you ask me what are the two critical reasons why an IUI will always, or the success rate of an IUI is primarily because of the timing of your IUI and also the presence of a superovulation in most of these cases. Obviously, you should also understand when you're talking to your patients regarding a procedure that can be done for them, we should also have a realistic picture of the success rate of these procedures in these patients and understand that with the advancement of age in these group of people, our results will tend to go lower. But again, even though we do have more and more data coming up saying that yes, in patients as far as paternal age is also important, but again, if you look at most of our IVF cycles or most of our centers who are doing IVF, you ask them which is the group of patients whom you are having the highest results, will be donor oocytes patients. Obviously, most of the donor oocyte patients will have older husbands, and if the results are going to be that significantly low, it would not be that significant. So what are the basic prerequisites when you're doing an IUI is at least there should be one tube that is patent. We should have a reasonably good ovarian reserve. There should be evidence of ovulation. You should know that this patient is actually ovulating regularly and should have a responsive endometrium. Whereas males are concerned, at least one thing that we should look at is at least they should have a total progressive motile sperm count of more than 5 million. 5 to 10 million should be good enough. But again, once it is less than 5 million, the results keep coming down. Then comes to the question is how to do an IUI, or what are the things that we should look at when you're doing an IUI. Do we need to superovulate or not? Is again the first question. See, but again, let's not generalize the term that IUI requires superovulation. Let's say in different scenarios, the requirement of superovulation might differ. For example, a patient with sexual dysfunction, like I told earlier, in that patient, we never know the fertility potential of that patient even with one oocyte. So in those situations, probably when you're doing an IUI, even with a single follicle or when there is no ovulation, like when they're having a regular ovulation, that itself is fair enough or good enough to give you a pregnancy. Whereas in situations like, for example, an ovulatory dysfunction, you know that you need to induce. But again, unexplained factors. Where unexplained, you know that this patient is ovulating regularly. The patient is having regular sexual intercourse, still not getting pregnant. So in these group of patients, it is important that you need to superovulate them so that we get more than one oocyte available for fertilization and hence probably get the possibility of a pregnancy. And again, the induction, as far as ovulation induction in these kind of scenarios, needs to be very carefully monitored. Should actually make sure that we maximizing the benefits in the sense that we get good number of follicles. When I say good number of follicles, does not mean you need to get 4 or 5 molecules, but we need more than one at least. Say 2 to 3 would be a good number of when you're doing an ovulation induction. For an IUI, 2 to 3 will be a good number. And you should always make sure that when we are able to kind of pick up some kind of a complication that is there, it's important that we look at it. Do we need to monitor an IUI cycle? What are the information that we are getting by monitoring an IUI cycle? Is obviously, yes, we are able to see a follicle develop. We are able to assess the endometrium. We are able to understand when we need to give a trigger. We are able to understand when we need to do an IUI, and also detect all these complications much in advance so that we can decide whether we should proceed with an IUI or not, or detect these patients like hyperstimulations to be much earlier. Like I said, monitoring whether it is required or not, they say that as per the NICE guidelines, they did talk about saying that yes, only when you're giving a patients with gonadotrophins, we need to have monitoring. But I wouldn't put it up like basically a drug. See, the whole purpose is we have to make sure that all the processes happening correctly. For example, you end up seeing a lot of people, PCOD patients, anovulatory PCO patients, you always give them, okay, clomiphene citrate from day 2 to day 5, and progesterone tablet from day 15 to day 30. It's a very regular practice. In that particular patient, you really don't know whether they're getting the menses only because whether the ovulation has happened or not is not clear. And patients continue to give these kind of protocol regularly for patients without monitoring. So I believe if at all you're doing an IUI, it's important that we actually monitor them. What are the ways in which you can monitor? I think without any doubt, we all understand, do this procedure like an ultrasound very frequently. And if you have the time and effort to do it, normally we don't do plasma estrogen levels except in situations where we are suspecting a hyperstimulation, or we are suspecting not a developing follicle in those scenarios only we end up doing a hormone estimation. Again, if you have the expertise to do further ultrasound parameters like color Dopplers and things like that, we can probably give you a little more insight. And without any doubt, ultrasound still remains the top, or ultrasound is the most important parameter where device through which you can actually monitor an ovulation reduction. Then coming to a very critical question as to what is the or what would be the timing of trigger, because like I said, what I always believed that was, as far as an IUI concerned, the timing of the IUI is the most critical. When you say timing of the IUI, timing of the trigger is important. So the first important thing that we need to look at as far as the timing of IUI is to make sure that you end up seeing a follicle which is at least of 17 millimeter and above. Now, it is not only the follicle. The two minimum things that we can actually look at is both the follicular size as well as an endometrium. If you feel that the endometrium is still not thick enough, just wait for 2 more days and make sure that you give the trigger only after the follicle is of 17 to 20 millimeter and the endometrium is of more than 7 millimeter. And the second question is, so in 90% situation this is enough. We can get away with this kind of monitoring and we can go ahead with the trigger. But what are the additional information that we can get using other procedures like Doppler? For example, we can actually look at the perifollicular blood flow of the follicle. If it is more than 75%, it is understood that probably the maturity of the oocyte inside that follicle will be good enough. The presence of a peak systolic velocity of the blood flow in that perifollicular blood flow, if it is more than 10, is an indicator that the follicles are mature. Again, the endometrial blood flow. So for example, you see a good follicle, a good endometrium, but you're not seeing a good blood flow around the follicle. Probably this is one place where you can actually delay your IUI for a day or two. Nothing is going to happen. And what we have seen is when you're not seeing a blood flow, if you wait for 1 or 2 more days, see the blood flow, then give the trigger, definitely your outcomes might be good, because you might end up seeing a lot of scenarios where you end up doing an IUI correctly when everything is looking happy and you don't end up getting a pregnancy. If you have more interest in ultrasound, if you can focus more on your device, like you using a 3D or 4D ultrasounds, in those circumstances we can do one step more where we can actually look at the uterine artery Doppler also, and also looking at the endometrial volume as well as the even identify the presence of a cumulus ovorus inside your follicle. How do you identify whether ovulation has happened? Obviously, the simplest way is to make sure that you see a follicular areal which has disappeared. So this can be only understood only after only if you are monitoring the patient. So it is important that we actually monitor the patients to identify when the ovulation has correctly happened, and never look at one particular parameter. For example, a patient is coming to you on a first day of a follicular study visit and suddenly you end up seeing a periovulatory endometrium, little free fluid, nothing in the ovary. Or it looks like a corpus luteum. So you know that probably the ovulation has happened even before we started the monitoring properly, or probably our monitoring was a slightly later. You called her on probably on the 12th day. The ovulation has already happened. So it is important that you combine multiple parameters, and that is going to help you in deciding or understanding whether the ovulation is happening correctly or not. With regards to the number of follicles, like I said very earlier, depending upon the indication, if it is a normovulatory patient, obviously the whole purpose of doing an induction is to have multifollicular development, and I would say 2 to 3 follicles would be an ideal scenario. As per the current law, even though we talk about saying of cancelling an IUI if there are more than 3 cycles, yes, in most of the circumstances, I don't know if people still follow that, but definitely when you end up seeing a multifollicular development with a lot of follicles, obviously we'll want to avoid doing an IUI, because this is one particular place we have absolutely no control of the possibility of multiple pregnancy. For example, now nowhere in IVF we get pentaplets, pentaplex, hexaplets, quadruplets. The only place where we actually end up getting these kind of higher order multiple pregnancies are always in IUI or in ovulation induction. With regards to semen preparation, as far as we know, it is understood that whatever may be the different semen preparation techniques that are regularly available in your lab, like your regular swim up or density gradient, both of them are equally effective. We can use whichever is available. Very important factor is the time that is taken from your preparation to doing an IUI. Probably that is a very, very integral part of, because especially in busy centers where you end up having the patient go give the sperm, prepare by the time the sperm is prepared, the doctor is busy doing another procedure. So in those circumstances, you should not delay the sperm. See, when we say that, especially in a normally sexually active patient, the sperm has the possibility to survive inside the vaginal mucosa for almost 2 to 3 days, whereas in a post-washed, when you're actually removing the serum around the other contents of the seminal fluid, and only when you're using the sperms, the longevity of these sperms are definitely reduced, because the protective environment that is given by the seminal fluid is no more there. With regards to the different techniques that are available, definitely I think that is, I need not be emphasizing on it too much, but definitely we should always try it and do it as gently as possible, as atraumatic as possible. Make sure that you're only injecting very less volume. I think it's not like they're giving, so there is this whole concept of people that they talk about of whether they should have an abstinence prior to an IUI or not. See, we always tell a patient, as far as that they are able to collect sperm and give, even if they have sex in the morning and come also, it is okay. Because it's not that if they see, if there is a shorter abstinence, what is going to happen? The only difference is going to happen is they will not be able to collect large volume of sperm. It's not that he produces 5 ml of sperm and I'm going to put 5 ml into the uterus. Ultimately, whatever sperm he is producing, I'm going to wash it, concentrate it, select only the highly concentrated into a 0.3 ml to 0.5 ml, and that is all what I'm going to inject into the uterus, because we do not want a larger volume to be injected inside. Obviously, if I don't know how many people will have this liberty and luxury of having an ultrasound next to your IUI room, wherein it becomes a little more easier, especially in difficult cases. With regards to the kind of catheter that can be used, as far as today, unlike your embryo transfer catheter where they say that the soft catheters are better, with regards to IUI, we do not have any evidence to say that whether a rigid and a flexible, rigid or whether it's a flexible IUI catheter, both gives us equally good results. Then coming to the whole concept of whether we should do a single or a double IUI, I think without any doubt, it is now very clear that in a properly monitored patient, a single IUI is as good as double IUI. So why simply bring the patient 2 times to your lab or 2 times to your center, collect the sperm, preparation, cost, all those become significantly higher. But what happens is, probably in certain circumstances where they say that you can actually do a double IUI, especially in patients where the semen count is very low and you still want to attempt doing an IUI, because you are trying to concentrate the maximum amount of sperms and put it at 2 separate intervals. So making sure that whenever the ovulation happens, it is there is some sperm that is surviving inside the uterus. Another circumstance they talk about is when you are actually looking at a Doppler monitoring of these follicles, and you see the Doppler, the peak systolic velocity, I said, of more than 10 is mature. When it's more than 20, it's tend to be a situation where probably the follicle can rupture anytime. So probably the ovulation might happen a little earlier. Not otherwise, what happens, we do it today, we do a trigger today, and 36 hours after later is when we do an IUI. But in this circumstance, probably the ovulation is happening slightly earlier. In those circumstances also, if you are doing a timing on IUIs, 2 separate IUIs, that is after 24 hours and then again 48 hours, it might be of benefit. With regards to luteal support, again, the question or all the data that we actually look at says that in patients whom we are giving oral ovulogins, you don't need to give luteal support. But if you actually look at the basis of this particular study, and if you can actually look at the number of follicles that are developed in a normo-ovulatory patient, after induction, they are still producing 1.2 to 1.3 eggs. So ultimately, they are producing only 1 egg. So even after stimulation, after producing 1 egg, you don't need to give a luteal support, is what the study is. But if you look at this particular study, again, they did talk about that when you're doing oral ovulogins, you don't need to give luteal phase support. But when you're adding gonadotropins, you need to give luteal phase support. So my logic or my thought process in this is, it is never to do with the drug as well as the response. Now, why there is a luteal phase deficit? What happens? The luteal phase deficit happens because of the high estrogen level. So rather than saying that it is 1 follicle, okay, probably when the number of follicles are low, like 1 or 2, probably you need not give a luteal phase support. But when there are more number of follicles, it is important that we give a luteal phase support in these group of patients. Situations where we should not offer an IUI will be the second scenario. Obviously, we know that special indications like grade 4 endometriosis, bilateral tubal block, severe male factor infertility, older age group of patients where we should not provide them with, we should not do an IUI. When you see a multifollicular development where we are suspecting a good semen sample where we are expecting multiple pregnancy, in those circumstances we need to make sure that the IUI is withheld. A lot of people don't talk about the kind of the process. See, unlike a normal situation where you are actually doing an IUI, imagine the patient is brought to the lab, brought to the hospital. The husband is asked to go and collect the semen inside your collection room. It's coming out, the semen is prepared. See, collecting the sperm itself becomes a big challenge for that person, because it is again some kind of performance anxiety comes. As long as the performance anxiety comes, the challenge is that semen that is produced, probably the quality and the DNA fragmentation also increases, and with the amount of DNA, the amount of centrifugation that is increased when you're doing most of these processes, your DNA fragmentation also increases, which can actually ultimately decrease your possibilities. With regards to the number of IUIs that should be done, what is technically understood is that if the IUI will be successful, it should be successful in the first 3 cycles, 3 to 4 cycles. They say 80% of them will get pregnant within the first 3 cycles, whereas 90% of the people will get pregnant within the 4th cycle. It is not that they will not get pregnant after that, but the possibility of them to get pregnant after that is very less. Again, repeated IUI also has this whole disadvantage that when you're doing, because there was a point of time when we had actually come out of college and started working in the fertility department, they were thinking about, as long as the patient is not having money, let's keep doing an IUI, continuously keep doing an IUI, because at least we are doing some treatment rather than not taking for IUI. So we should always have a point where you should understand that we should stop doing it, because sometimes you are doing more harm than good, because the kind of endomyositis that come, that your IVF outcomes also in these group of patients will be significantly reduced. So to conclude, what I want to understand and tell here is that when you're actually selecting your patients correctly, selecting the correct group of patients, doing the procedures correctly, definitely IUI definitely has a role, and please avoid doing this procedure just for the sake of doing it. Thank you so much for your patient hearing.
Thank you so much, doctor, for your valuable insights.